I've been asked to present a little bit from the Australian context, and I assume most of you have heard from Margaret Hallard a number of times, so I won't cover too much of the epi, but just to give you a bit of background around the Australian context. We have had access to DAAs universally since 2016, and they have been made available to anybody living with hepatitis C, so no restrictions. And we were lucky enough to receive access to DAAs, and they were provided to through GP specialists, and now nurse practitioners are also allowed to prescribe. So we have a very broad prescribing base, which has really helped ramp up our treatment access. So this slide just demonstrates the pattern of access to hepatitis C treatment, and really there was a significant increase in treatment uptake following the release of DAAs onto our public prescribing system. And really, since then, we've had this slight decline and really a plateauing in treatment uptakes, as you can see here. So to date, we've reached about 70,000 treatment initiations, and in total, that represents around 22% of all the people living with hepatitis C in Australia. You can zoom in a little bit more and you can see we've had a pretty steady decline since our early treatment initiations, and this is really evident of the initial warehousing effect, and since then we've had a pretty stable about 10,000 treatments a quarter. You can see here in the early stages of 2018 it looks pretty stable, so we're seeing this sort of plateauing effect, which is definitely concerning for our elimination efforts. When we zoom in a bit more to look at really who is prescribing the bulk of the treatments or where people are actually accessing treatments, you can see that it tells an interesting story that initially it was really at the liver clinic, so through specialist tertiary care, and more so now we're seeing a lot more of the prescribing happening out in primary care. So this is delivered through GPs or general practitioners, predominantly doctors. This was our cascade of care in 2017. This is using our national data, and you can see at the time we estimated that we had treated about 15% of the population. And really you can see here that Australia has done quite a good job in terms of testing our at-risk populations. You can see there's an estimate of 80% of people diagnosed, and I have to have a disclaimer here that this is really an estimate of antibody testing, so screening rather than actually diagnosing people. And I think that is one important consideration, and I think Manal has really highlighted that there's got to be a really important link between your screening and then you're actually diagnosing active infection. So I wanted to highlight that really, while focusing on treatment and linkage to care, that in Australia we're going to have this issue where we'll actually run out of people to treat if we don't manage to increase our testing. So this complicated graph, the left-hand kind of red graphs, really were the treatment uptake graph that I had before. And on the right side, this is our testing. And you can see here that unfortunately we're getting a drop-off in testing as well, and this could be contributing to a reduction in treatment. But this is not looking good for us. So while I think Australia has really done an amazing job at getting those initial probably 20–30% of the population tested and treated, we are going to run into this issue where we have to keep testing and actively case finding people to get them onto treatment. And you can see here that this is not inequitable testing that we get, that we're going to have a pretty big issue in terms of finding those younger proportions, and I think Manal has really highlighted that they've had a really big impact in terms of reaching that younger population, which is something that Australia is not doing a very good job at the moment. So where to now? I think Australia, we're really focused on increasing the levels of testing, and that's so that we can continue that treatment uptake, but also identifying strategies to increase linkage to care. So really we have to understand the number of barriers that exist currently in terms of getting people onto treatment, and these are just some, which I know a lot of speakers have already covered today, but we know that there is uneven coverage of services. This really pertains to Australia's large geographical area and rather a very small proportional population. So really for us, we've got an issue around coverage of health services. In addition, when you look at specialist or tertiary care, you can see even more so. So there's really only coverage of specialist services in kind of the larger areas or larger cities. And so really for Australia, this is one of the driving reasons why we knew we had to move beyond tertiary specialist care into primary care pretty quickly. I think probably it's unanimous now globally that we really need to think about how do we shift treatment out of specialist tertiary care and into primary care where you'll really get good coverage of the population. And these are just a number of different settings where we really have to think about targeting testing and treatment. So thankfully there's a lot of data coming in. Every conference there's another 100 or few abstracts and papers coming out in terms of really what's our evidence base for improving testing and treatment, particularly for linkage to care. So I'm not going to go through these all, just to show that there's a real body of evidence that's growing rapidly, and that for most of our settings, that there'll be some example next door, the country next to you, or the country in your region that you can really look to help guide your strategies. So I want to talk about a few examples that have really just helped Australia think about some of the issues around linkage to care. So this is a randomised control trial that was really trying to demonstrate the effectiveness of treatment in primary care versus tertiary care. This was the design. People were recruited initially at a primary care setting, then they were randomised to have the rest of their care either delivered in primary care or they were referred to a tertiary hospital, which was the kind of mainstay of treatment care prior to this. And you can see here that the study really aimed to determine if treatment uptake and also SVR12 was similar across primary care and tertiary care. What we found was, it wasn't just similar, but it was actually better in community settings. And this really gave us a lot of support for ensuring that we can roll out treatment, testing and treatment in primary care. But when we looked at active injectors, the improvement was more marked. So you can see here that when we compared the proportion of active injectors among this group, there was 72% that received treatment amongst the primary care arm versus 26% amongst the tertiary care arm. So here again, just giving us really good, solid evidence that DAAs in primary care actually increases treatment uptake amongst people who inject drugs. The next study is a much smaller study, which was looking at whether we can start using point-of-care testing to engage people who inject drugs in testing and treatment. So this is really a pilot that looked at introducing rapid point-of-care testing in needle and syringe programs. So in Australia, we have very, very good coverage of needle and syringe programs, but they don't often have health services delivered through them. So sometimes they might be a cupboard in a kind of office space, or sometimes they might be a whole entire service co-located in a larger community health service. So very variable. And we wanted to demonstrate that we could actually reach either new people who aren't already engaged in care if we'd started to deliver testing and access to treatment in these settings. So this was the protocol. We used the OraSure or Quick to do an antibody test and then really reflexed onto the Cepheid RNA test. We also had people return for visit 2, which was really to have their confirmatory test done through standard laboratory testing. At that stage, they were also then eligible to be triaged into treatment. What we learnt was a fair bit amount has to go into setting these systems up, and I'm sure Manal has covered a lot of that really it's important that you get these systems working so you don't create new bottlenecks in your new system. And that we were able to reach a high proportion of really vulnerable or at-risk populations. So there was a lot of people who were living in unstable accommodation, they're active drug users or injecting drug users, and pretty variable experiences of hepatitis C care. So some of them had already been engaged in care and were kind of regularly getting tested, but most really hadn't been tested in the last 12 months, and some hadn't been tested at all. So here we are seeing that we are reaching a new population of people at risk that probably aren't engaging in ongoing care. When we looked at the acceptability, we recruited 174 participants, 150 had a reactive antibody test, and 93% of those went on to have their RNA test, and of them, about 50% were RNA positive. So this is just highlighting to us that this is a very high prevalence setting, and it's definitely worth our investment in terms of the number of people we can potentially reach. In terms of feasibility, we wanted to demonstrate that this was an important setting to reach new people. And we noticed that there were a few things that will hinder maybe the scale up of this approach, and that is that a lot of people were not willing to wait on site for the result of their rapid tests. So the antibody test is a 20-minute test, but the RNA was a 2-hour test, So it's not very, in an NSP setting, people are coming in to pick up their fits, really a few minutes, and they're not likely to stay for 2 hours to get their test results. So this was an important lesson for us. Most of them opted for a phone call or a text message. And then when we looked at the number of people actually returning for that second visit, it was really high. And this gave us some inclination that even though people weren't really willing to hang around and receive their result, they were engaged and willing to come back for that second visit. And most people returned for that second visit within a median of 11 days, so relatively quick turnover. This is the treatment cascade. So really for us, 57%, it did look better than our previous cascade in 2017. So in a small NSP setting, we actually had pretty good treatment uptake. And what we learned was that the 3 different clinics actually had pretty variable treatment uptake and linkage to care. So in this clinic, it was a bit higher than the average, 74% treatment uptake. In this clinic, a lot lower than the average, 29%. And the third one, 72%. And this also gave us some idea about scale up and really how you invest in these new settings, that you won't have a standard of care that you're expecting, and there will be some issues around how efficacious these new settings will be. Some of the interesting findings were really around the acceptability of this model, and for most people it was around convenience. So the 2-hour waiting period was definitely not convenient, but having testing offered in an NSP setting where they weren't usually offered testing was very convenient. It meant that they actually could take up hepatitis C testing without having to go to a health service, without really having to do anything else. So this was seen as a real advantage, as well as having a relationship with a lot of the NSP workers. And I think that was a really important part of it. So concluding, I just wanted to highlight that really in these NSP settings, we were able to have a pretty big impact in terms of testing a small proportion of people, but really that the treatment and linkage to care was really high in these settings. And I think part of it was really having an effective engagement tool for this population. So the last study is one that I spent a lot of time thinking about, and it's really a multidisciplinary approach to hepatitis C elimination. So this is a program that we run across our entire state, which is the second largest state in Australia. And this is a very complicated diagram, but really just to show that we're trying to think about how we might roll out an elimination strategy in Victoria. And these are all the different components that we have to consider within that framework. So a lot of the work we're doing on the ground or in the community is really around health promotion, thinking about what's the types of messages that we need to deliver to the population at risk? How do we increase awareness about the new treatments? How do we sensitise them to the models of care that we'll be delivering the treatments in? Secondarily, looking at the actual workforce development issues. So this is a lot around training new workforces. As I mentioned, we now have GPs and nurse practitioners able to prescribe. However, there isn't necessarily an investment in the training for these new workforces. So this is a big bulk of our work, is thinking about how do you actually train up these workforces to start delivering hepatitis C care. And the bottom 2, implementation research, so that's a bit around that rapid EC study. How are we starting to think about alleviating some of those barriers in the cascade of care that we're already aware of? So we already know that people will drop off after diagnosis, they'll drop off after they've been given their diagnosis, they drop off after treatment, they drop off after being given a prescription, having to go then to the chemist to get their get their drugs, they also tend to drop off there. So we already know that there's key points that we want to be trying to intervene, and this is what a lot of our smaller research studies are trying to fill that knowledge gap. And the last one, probably the most important for our state, is that we've got a really robust surveillance system which allows us to do some really interesting things in terms of evaluating a lot of the interventions that we're putting in this setting. So our approach is looking at whether we can increase demand through health promotion, whether we can increase clinical capacity through training and education, whether we can really streamline the clinical pathway. So that's simplifying the stages, ensuring that we're trying to minimise that loss to follow-up. And the last two are around establishing a robust surveillance system to really answer some of the monitoring questions towards elimination. Now, in Australia, I have to say that one of our biggest lessons is that while we can have access to treatment in pretty much all settings, what ends up happening is that you don't have a best practice model anymore, because you have to be very, very flexible to all the different types of workforces, all the different types of settings. And as I said, there's no one best model. So I think that's an important point to make. And I think Manal actually had some nice examples of where they've got a few, maybe 2 or 3 models that they think are really working, and they're driving that out. And in Australia, I think we're probably more hindered by, now that we've got this really widespread access to treatment, it's much more difficult to deliver kind of a standard of care. But one way we've tried to address this is by developing sort of resources that try and provide almost like a toolkit and stepping kind of providers through. So all the different types of providers that are engaged in hepatitis C care can really use some of these toolkits to intervene, I guess, where they're related. So if you're a nurse and you're really involved in the screening, you've got a section here that really just talks to your kind of area of work. If you're a healthcare worker and you're really involved in the kind of engagement, patient support and the linkage to care, there's a section for you, versus if you're one of the prescribers, that there's a whole section around kind of steps A, B and C on how to prescribe, and really a bit about follow-up and some of the things you need to be thinking about, reinfection and surveillance. So I think this has been one of our key lessons, is really how do you develop some of the tools that will enable scale up across Australia. And I think we've been really lucky that we've had funding to develop some of these tools. We went through a process of co-designing them with providers, with clients, with community groups. And we were able to really identify some of the key issues for providers, and they are around incentives for billing and also how much time they have in their busy clinics that they can take on something new like hepatitis C care on top of the work that they already do. And lastly, to bring it all together, is that the surveillance component really helps by driving responses. So this is our cascade of care at every service. So every clinic gets a site report, and it gives them their own clinic data, a mini cascade for their own service, to really help motivate them to ensure that they're addressing some of those barriers you can see evident in this cascade of care. So ongoing challenges and opportunities. We still don't have a good set of interventions that addresses stigma and discrimination, and I think this will be a major issue for a lot of different settings. We need to start promoting the positive benefits of treatment. I think that starting talking about sort of liver cancer prevention, also the kind of improvement in quality of life to help really encourage people to take up testing and treatment. And the last one, some innovations around strategies to enhance the linkage to care, or the cascade of care. That's all from me. Thank you.